Welcome to Planetary Health First, Mars Next. It is going to be an amazing journey today. Hope you are ready for liftoff. We are live now. Well, we are here today. Thank you so much for joining us at Planetary Health First, Mars Next. And we got some amazing guests. And usually I'm not this lucky to have two. And I would say M squared. But that's just my own really. And today is going to be about population health analytics. And today we have authors of a book, and they've been writing this story all their lives in healthcare. And so first I want to introduce at the top, Sylvia, PhD, MBA, RN. And so she's a force to be reckoned with. Don't mess with her when it comes to population health. She's been in the trenches. Currently, what she does is she's president at Forest View, and I don't know if that's a play on words because it's the view with data analytics. We'll get there later, but she's an associate professor at the Medical University of South Carolina. Go South Carolina, love the food in Charleston, but I don't think it's in Charleston. Maybe it is. And then John Hopkins, you've been on like multiple roles, which I'm not even going to mention because there's like 10 roles you've been there. You were a professor, or adjunct professor, faculty. But what I really would like to say, you were director of population health, as well as previous or earlier, director of care management. So I think that's going to be really interesting. I'd love for you to share a little bit. Just hold on that, or you go ahead, and then I'll get to introducing you below Ines, okay?
Yeah, you discovered a lot of information about me. That's great. My work is at the intersection of clinical care, business decision-making, as well as the analytics to be able to do so, really with a focus on value-based care and providing and understanding what large populations of people need and how to get them to what they need. And I really have a passion for helping organizations succeed in doing that so that we can improve the healthcare system.
Awesome. Awesome. Well, down below, we got Dr. Ines Maria Vigil, and she is currently the SVP, Services and Transformation, Clarify Health Solutions, And she was prior to that, Healthcare Innovations in Data Science as a CEO at IMF Healthcare Solutions. Prior to that, she was the VP, Population Health and Analytics, Priority Health, Care First. She was the VP of Innovations and Data Science. If you're seeing some sort of trend with data innovation, you're right. And she was at HealthWise Innovation VP, and then John Hopkins. And this is where she was the medical director of Population Health Analytics again. So go ahead, take it away. A little more about yourself.
I think you described it well. I'm a self-described data nerd. And it takes all three of my degrees, being a physician, being an analytically trained, and an epidemiologist, to do the work that we do. As Dr. Sylvia described, we work with populations. So identifying what the needs are of populations using data, and then matching it with the interventions that would have the most impact and that they would most benefit from. And working on the financial side and the business of health, of working with hospital leaders, health plan leaders, to craft benefits and to offer services that are really going to improve the health of the population overall.
Cool. So what are we going to see in 2024? What are you excited about in this realm?
I know I'm most excited about seeing what the initial impact of artificial intelligence is going to have on healthcare, and where in healthcare we can have those that kind of technology be infused in responsible and ethical ways, so that it can actually bring forward some innovation and some needed change to the way we think about how patients access their healthcare services.
All right. So Ines has AI. She's interested in that. How about you, Martha? What do you see in 2024?
Yeah, it's interesting. I was just reading an article today that over the next 3 years, we're going to just see a boom in the transition to value-based care. So I'm super excited about that because organizations are really hesitant to dedicate too much of their budget right now to the tools and the technology that are needed to succeed in population health. So a lot of times when we're doing that work, we're kind of doing it off the side of our desk with people who also are involved in the operations of fee-for-service care delivery. So I was super excited to see, you know, over the next 1 to 3 years, we are just going to see it explode. So those budgets will have to support what's needed to be able to be successful in value-based care.
The biggest thing leading us to value-based or blocking us to value-based?
The biggest thing blocking us to value-based care, and I know Ines will have thoughts about this as well, I think is that we're still operating in a majority fee-for-service world. And so we have to dedicate our operating budgets to that fee-for-service world, and we have to still think about increasing volume, but at the same time where we have about 30% of our revenue from value-based care, we still have to succeed there too. So, you know, hospitals and health systems operate on a very, very thin margin. We hear about hospitals going out of business all the time. So they can't operate in two business models. So that is the biggest challenge right now to really going full-blown value-based care. Ines, I'm sure you have other thoughts.
I agree. I think it's all about the big picture. And right now, the way that the fee-for-service hospital health systems work is not about the big picture. It's still about profitability, revenue generation, differentiation, and marketing, and providing services that drive those main factors. And I think in order for us to go big and really be successful in value-based care, it really requires organizations to think more holistically about the social, the economic, the environmental factors that all influence health, and being a part of the solutions to those and in the communities that they serve for the populations that need them the most.
So you have this huge wealth of data. Where do you even start? I mean, it must be like, how do you bring it down? How do you boil the ocean to a point where providers or you can impact or make it work?
Well, first you bring Martha and I in into the conversation. That's the first place you start. It's such a good question, simply because that is one of the biggest challenges I think we see, particularly provider organizations in healthcare today, is that it requires a level of sophistication and maturity to not only be able to craft the data that you need, but then it's a skill to interpret it and translate it into something that can be actionable. And whereas like data can be the fuel, really it's the humans and the skilled, you know, folks that are trained to do this type of work that are the engine. And I think it takes a village. It takes, and Martha and I write in our textbook, and Martha can elaborate more on this, but we call it the team troika, which is, you know, the business leader working hand in hand with the clinical leader, working hand in hand with the analytic leader. And we've since even added another component, which is that health equity component of that whole person comprehensive care that brings in the community and the environment and all of the factors, genetic factors that make up what a person's health really is today.
So where do we go?
Yeah, well, Martha, maybe we can talk about, because I love having the opportunity to collaborate with you, even in moments like this. And maybe we can talk about where we often get pulled in, where there seems to be challenges or gaps in organizations being successful at both really serving populations with data and or moving into a value-based care world.
Yeah, I think one of the biggest challenges when I get brought in is organizations are stuck. They are in a value-based care contract, and maybe they're working on quality measures, but they don't know what the next steps are for actually being able to identify populations, identify those needs in a population. What are the drivers of health outcomes, and how can you mitigate those drivers that are resulting in poor outcomes? And they know that they need to do it at an executive level, but they don't know the first step to be able to take to do that. And so every organization is at a different phase in their journey. You know, they might be just at working on Excel spreadsheets and receiving lots of data files and having them in a folder and not knowing what to do with them, all the way to maybe having a data warehouse where they put all their data in the data warehouse, but then they don't have it modeled to be able to allow them to easily assemble populations at will and be able to understand subgroupings of those populations and be able to tease out health determinants, those things that we know from the literature and from evidence that drive health outcomes, to be able to actually measure them in their own data. So that point being that organizations are at all different phases of their journey to getting to value-based care. And, you know, Ines and I are able to go in and identify where they are in that journey, to be able to assess the organization's capabilities in being able to do population health analytics, meet them where they're at, and then take them and join them on that journey together.
Who is the individual, the stakeholders at these organizations that throw up their hands and reach out to you?
Yes.
Chief medical officers, chief population health officers, CEOs, CFOs. I certainly do a lot of work on building out return on investment models, even being able to guide executive teams on, should there be an ROI on this, or is it simply an investment in the communities that you serve? And what can that return look like? And how can you use or distribute those funds or allocate the funds that you have to the resources that are most needed to create the biggest impact or the greatest benefit to the populations themselves?
So this is going to sound like a really dumb question, but when I think of physicians providing, it's always less and less, trying to do more with less, getting paid less with the reimbursements, right? So it sounds like either you retire. My dad's 91. He used to be a doctor, so he's not having to do that right now. So he was in the heyday. But what I would imagine, if you're not at a certain age, 10 to 15 years prior to when you're retiring, you're going to have to say yes to VBC, value-based care, because I imagine you want more of the pie, and the only way to do it is this. Is that correct, or am I wrong?
I think it's spot on, honestly. I think where the challenges exist are in physician and clinician burnout. And the COVID-19 pandemic really tested our healthcare infrastructure and showed our flaws in the way that we're able to really understand what the needs of populations are, how to best serve them, and how to be nimble and flexible to those needs when something like that occurs. And in this day and age, you know, there's so much clinical information. As a clinician, there's no way that I can keep up with the amount of scientific evidence that's out there in the clinical world, and let alone know what's going to have the greatest impact for the person that I'm treating at an individual level, or at a, you know, hundreds of thousands, tens of thousands, hundreds of thousands, millions of people that we're serving across the US or around the world. So I think this is where data really helps. It helps to tell the stories of what is it that would be most needed, and then whether or not the services that any given hospital or healthcare organization is providing matches. How well does that match with what the community needs? And then what is the potential impact that you can have on the health of the community that you're serving? And it happens in pockets in different places, but it's not happening at the level that it could or should. I think, to Dr. Sylvia's point, with the investment that's required and the model, the financial model that's required to really support those types of efforts, it's just not there yet.
So are hospitals a fan
of value-based care? Well, there were a couple instances actually during the pandemic where elective surgeries became just that, elective, preference sensitive, what we call, which is, you know what, if you could hold off on that knee surgery, that knee replacement surgery, you did, because it was not a good time to be in the hospital and risk getting catching COVID or and risk, your own health and dying. And so there were a lot of folks across the country who put off what would be considered preference sensitive procedures. And what that did to hospitals across the US is it reduced their revenue dramatically to a place where they really needed a different type of revenue or a different type of income to come in the door to be able to pay all of the bills and expenses that they had. And those organizations that had already really learned how to be successful in delivering outcomes-based care and value-based financial arrangements, they survived. And they survived in a way that really benefited both of the organizations, the health insurance companies that were part of that contract and the organizations that were giving the services to those patients, because it was no longer about volume. It was no longer about how many services do you provide and how much do you charge per service. It became about what does that patient need right now and how can we get them what they need, how they need it. And that's it. And I think that's really the story I think that value-based care has to tell and outcomes-based care delivery has to tell, is like, what if we really thought about healthcare in terms of what people need, deliver it in the way that is best for them, and then monitor the population to see what the impact is to the overall health. I think we'd see a very different outcome than what we do today.
So what about ACOs and value-based and this how do these intersect? Give us a little bit of backdrop, maybe unpeel that onion.
Unpeel the onion of ACOs and how they intersect with other organizations, healthcare delivery organizations?
Well, I guess it looks like from my research, it looks like you both have been providing value, doing work with ACOs, and there is no ACO success without population health analytics, without doing what you're doing. So just sort of, can you unpack that? I'm sorry, my question was really bad. So anyway, thank you for being here.
Yeah, I can give a very practical example of like how data can really uncover insights that may not be so clear when you're delivering patient care one patient at a time. And I think this is what accountable care organizations and are really trying to accomplish. In one instance, I was analyzing a set of data for a large payer, and there was a really high readmission rate across a population of patients. When looking more closely at that readmission rate, we could parse out different health conditions that were driving those readmission rates. And we saw a group of patients who had different neurological conditions like Alzheimer's and Parkinson's disease, which are, diseases that limit, the ability for somebody to just basically do self-care, dress yourself, bathe yourself, daily tasks like walking around and doing your own laundry. And what we found was, and this is the power of combining the social determinants of health data, what we found was there was a huge component of these patients who didn't have what we call adequate caregiver support, which is there was nobody identified in the home that was consistent enough to be able to meet their daily needs in a way that, didn't put them at risk of a fall, of an infection, of, harming themselves just trying to do daily tasks. And because of the underlying cognitive decline in some of the Alzheimer's patients, it made it difficult for them to even verbalize what it is that they needed. And so we saw the opportunity really to increase the caregiver support in that population of patients. And what that really provides them is a way to reduce the readmissions because they're not going to the hospital for that care. They're not going to the ER because something never happens. That event that triggers them to go to the ER because of a fall or an infection or not being able to verbalize what they need and somebody anticipating their needs, it creates an event that requires them for an ambulance to be called and them to go to the hospital. And that creates on average $36,000 bill for an admission or a readmission. And what we find is that when you look at the root causes of it, it's completely preventable. It's preventable in a social way, not necessarily a clinical way.
You know, you're spot on. You know, I can say that I'm experiencing that, not directly, but my dad's 91. All the situation that he needs is that wheelchair, the 3-in-1 commode, the raised toilet seat, the hospital bed, and the rolling walker and all that. If that hadn't been set up, I mean, he's fallen, but those things are huge. It's just life changing. You know, he's able to get from his bedroom to the bathroom, but without those things, he'd never do it. And he feels comfortable and confident. And I'm telling you, life changing. And I know I'm not trying to make this silly, but it's the truth. I mean, the bath, the actual the shower bench. My gosh, he's no longer afraid to shower now. I mean, it's like, yes, he'll shower.
It's a safety issue.
Yeah.
Right? And that's not a prescription necessarily.
And my dad has dementia. I mean, he has dementia. He didn't want to vocalize that he's afraid, you know, he couldn't at the point where he is. So more of that, just a simple PT home assessment. Bam, got that. And the $36,000 for one hospital, you could have a caregiver for almost a year. So anyway, I'll stop. I'm not supposed to be talking about.
And that's outcomes-based care. That's the easiest way to think about how it works, is if you were to divert some of those funds that you're already paying for to the things that would prevent the event from ever occurring, you're creating a wellness, a well-being for that patient that didn't exist before. And you're really bringing like confidence and security to the families as well. And you're preventing that, not just that one occurrence, but that occurrence from repeating itself over and over again in the same patients, which Martha and I see in the data all the time.
So how do we get hospitals to do this? They need people to come in those hospitals too. What do they do? What's the way to get them to help? Sorry.
So that question is, we want to keep them out of the hospitals. So we want to empower the entire healthcare delivery system. And often when we think about healthcare, we think automatically hospitals. But we really, and it comes back to this question about data again. You know, hospitals and healthcare delivery systems have their data set up to be able to do operations. So they can count how many services they provide. They can count how much money they bill for those services. They can count how many events they've had, how many ED visits, but their data isn't aligned at a person-centric level. They can't follow people over time longitudinally to be able to identify those needs like Ines was talking about, to be able to identify, oh, somebody's having some decline. They were fine up until this year, but they just had a fall. Well, when you have person-centric data, that fall is triggered in that person-centric data set to then trigger, oh, well, now what is it they need to be able to prevent those falls from happening in a systematic way? Yes, that person can go to their physician and find out, yes, I had a fall, I might need a walker. But how can we trigger that in data so that the system automatically sends them a walker? The physician doesn't have to order it. So we, our entire healthcare delivery system, how do we get that to change? Hospitals are a big part of that. Hospitals have a huge role in providing acute care when it's needed. And we need that in this country. We learned that during COVID. But is it all up to hospitals to be able to identify these needs? We need the entire healthcare delivery system to be able to organize themselves in a way that is preventative and can trigger these needs like Ines was talking about, going back to the explosion of AI. Well, AI could lay on top of these person-centric data sets to be able to find that trigger for that first fall, find out why it happened, and get the deliveries, the entire system.
Automatically send an asynchronous video that teaches them about the precautions of falls, or the right questions to ask their clinician, or the right person to reach out to share the event, like to share what's happened and what to do next.
Well, I like how the two of you have really clearly kind of made this much more easily accessible, as much as you're, you know, and as you're a data, what do you call it? A data nerd or
a data nerd?
A data nerd, you can bring it to the everyday. So if I can understand, I'm sure everyone can.
Yeah, well, it's interesting because, health is so personal and it's so local, and we see it all around us, siblings, parents, grandparents, children, and everybody wants to do what's best for the family members that they care about the most. And everybody really wants to do good for themselves as well. And the hardest thing is knowing what the right thing is at the exact right time that they need it, and to know and be able to predict what that outcome is likely to be if you do it. And I think that's one of the things we really haven't cracked the nut on in healthcare is like, oh, if you eat that bag of chips or go through that drive-through, we haven't cracked the nut of like, you have a 22.7% chance of, having a heart attack 3 years earlier than expected. We
So
haven't
that we
really
want to
been
hear
able
it
to
when we're at the
tell.
drive-through.
Right,
Yeah.
and it triggers you when you're there because your
Yeah.
phone on your GPS says, hey, are you making a healthy choice? Here's an
Yeah.
alternative, right?
Sound-
We haven't quite gotten there, but I think technology and honestly analytics can really help us get there, and we're just on the cusp, just on the verge of doing those kinds of
I
things.
think we're going to need more of these coaches, the behavioral science, because, man, you can tell me every 6 months when I see my doctor every year, hey, you need your statins. And I'm like, oh, so it's so hard to motivate people, right?
Yeah, it is.
So, but anyway, so we're not finished yet. We got about 20 some minutes. I hope I'm really glad you guys stopped by. It's hard to get the two of you on the calendars, but thank goodness with technology, we're able to persevere. You're here with us. Where do you guys want to go? We got about 20 more minutes left.
We could debate
Well, one
a
of
whole
the
bunch
things, well, I love, and Martha, I'll propose an idea, but, one of the motivators of Dr. Sylvia and I writing the textbook was really wanting to train the future workforce that would be working with these concepts and in these areas, and really provide them with an understanding of the business of health that they would be working in. And because their training is so specific, right? Like if you're technically trained in analytics, you are doing anything from coding to engineering to, working with the data in a scientific way. If you're a business leader in healthcare, you're very specifically trained on how to improve the operations and the administrative functions of what's going on and how to think strategically about what that organization needs to have and be. And if you're a clinician, you're trained in all of the clinical aspects of delivering high quality care, right? And evidence-based care. So what Martha and I really wanted to do was like really understand how you could really intersect those three and provide information that could train the workforce that would have to work together to solve some of the healthcare's more challenging issues, and really move us from a thinking of, I do my role, or I'm hired and I play my role and I do my part, to one that's more collaborative, one that's more team-based, and really thinking about how we can work together to solve some of the hard stuff that we're talking about today. And Martha, I'd love your thoughts on kind of what that looks like for you.
Yeah, so I started doing this work over 10 years ago when I was at Johns Hopkins, working with some fabulous mentors there who really taught me how to start to bring this to healthcare organizations. And so at Forest View, what we've done is we've developed a team, it's called a Team View program. And we can go into organizations and we develop their capacity for being able to do population health analytics with their own data. So they might have a tool like Clarify at their organization. The tool is sitting there, but they're not able to use it in a way to understand and derive insights about people and where to go in population health analytics. So we bring together an analyst, a business leader, a clinician, and most recently a health equity leader, and we put them on a team together. And they identify a challenge in healthcare delivery. Like they might identify a challenge of increased ED visits for children with asthma. And so from an events-based approach, they might look at
what
like
would be
how many
defined
ED
as a
visits
problem,
are there,
right? A clinical problem.
in healthcare. Yeah. A clinical problem, challenge in healthcare that's costing a lot of money. And it's resulting in people having to go to the ED, the emergency room, unnecessarily. And so the team comes together around that challenge, and then they have to follow a process that they're given for a population assessment. But they're doing that assessment from a person-centric way. So they need to identify a population of people. Now, you would think that would be easy. But when you get those 4 groups into a room, they have very different interests about how they even want to define children with asthma. And so they have to go through this whole process together over 9 weeks, and they come out with how they can address those drivers of those ED visits from a person-centric perspective. So we can do other things, like we could system-wide, we could, have children who go to the ED go to another place to get their emergency care, but they're still needing emergency care. So when we're talking person-centric, we're talking about how can we impact those factors in that person's life that are making them have to go to the ED emergency room unnecessarily. And so the team gets together, they go through content that's similar to the content in our textbook, but they do it in a self-delivered e-learning modules through that mechanism. They also go through a team development process. So they start to learn each other's language, and they have to actually talk to each other. I can't tell you how, and I say that, like, they have to actually talk to each other. They get very upset that they actually have to spend about 4 or 5 hours a week together during this 9-week period to actually be able to work on a challenge they think they could solve by themselves immediately. Why do they need these other 2 people to help them solve it? So we go through this process together of team development, and storming is a real thing. Like, there's a team development process called forming, storming, norming, and performing. Storming is painful. Like, storming looks like, I do not want to do this work. I am going to go to the person who made me go through this session together and tell them I do not want to do it. I don't think that it's painful. And then we also go through learning this new way of approaching problems in healthcare, and that's the process part of it. And then we're using the data. So as a good example, one of the teams that we worked with actually, from a person-centric approach, looked at children who were having increased ED visits with asthma. And this is something that Ines and I worked on together. And what they found in the end, that there was a substantial group of children that actually had to go to different places, different times of the week. Like, maybe they were in foster care, or maybe they were part of their parents were divorced and they had to go between households multiple times a week. Well, the benefit
their grandmother
structure
took care of them 3 days a week.
Yeah. Their benefit structure only allowed for one type of each inhaler. So when they went, so when they went to these different, they're kids, they forget their inhalers, so they don't take them. So that would have never been discovered had we not taken a person-centric approach. So we could then change the benefit structure for these kids to be able to have more than one inhaler and have one at their different places where they spent the night. And so it's a very, simple example of how taking a person-centric approach can really change the way you're looking at a problem, and how you need to bring together those different roles. And analysts never could have discovered that alone with their data in a room coding.
So it's amazing while you bring people together and you make them sit at the table and start eating together. It's amazing. If all of us sit down, have food together and break bread, you actually might learn, and have some respect, and gosh.
Yes, we do learn respect for those different roles. And I will tell you, in a system where we send a request to an analyst to say, here, tell me, how many prenatal, why are we having increased, readmissions for women who are delivering after their pregnancy? And they'll give you a list back of all the DRG's diagnostic reasons why this group of 100 readmissions happened. That's, we need to be able to understand what each
and
other.
And then it's on somebody's desk and nothing happens to it. And so that's really where the clinician comes into play, because then the clinician can look at it and say, do I see anything that's happening in groups? Can I segment these groups and stratify them into what I think could be common ways in which we would intervene to help them? And then the business person layers over on top of that and says, great, now what's the impact to the overall bottom line, to the business itself? How can we measure this and say that we've done well for the populations that we're serving, and that we're making a difference in people's lives?
Well, if
Change
you look,
is super hard. Change is super hard for organizations. It is when you are coming into an organization and they are used to doing analytics in a certain way, they want to do it the same way. It's familiar. And so changing the paradigm to person-centric from event or admission-centric or visit-centric seems like, when we're talking about it, very small, but it is a game changer.
so if you're looking on the screen or you're listening to us, you would see Population Health Analytics. That is the title of the co-authors here that we have today on Planetary Health. That is the title of their book that they wrote. It came out in a significant time, August 16th, 2021. And that was the date that I guess you guys were in the middle of getting this thing going during post-COVID forth. I don't know what that looked like, but you persevered. And now with this, you actually have a guiding force to help healthcare move along, make it happen. And the only way you can do it, Ines, is huge. Both of you guys are in collaboration. Really, it's about the data, knowing the data, getting the data, but then having the different people, the different team members speaking one language on getting crap done or making it happen, right? Otherwise,
Yeah.
silo this, silo that. So
Yes.
that's what I got. And if I can get that from this thing, you should be able to too. So anyway, I'll stop.
I think you hit the nail on the head. I think this, and it's been such a pleasure working with Dr. Sylvia through the years, because I think this is what we discovered, this many, almost 2 decades ago, working together in the trenches on this type of work, was that the secret sauce wasn't so much in, you still have to have the data, right? It still has to be big data. And you still have to be able to know and have the skill sets applied. But what really makes the difference is the way that people are able to work together to solve something challenging that is complex and that doesn't really have an answer right away. And being open to what the data tells you is happening across those populations.
Now, is your book, the textbook, is it at Johns Hopkins? I would hope that a lot of these healthcare informatics, population health courses are using your book. How is that coming along?
That's interesting. We get periodic updates for adoption rates by universities. And so we talk to college professors. We actually talk to students here at MUSC, which, by the way, is in Charleston, and that's where I live and work. They are using it in their College of Health Sciences for their Master's in Health Administration program. So there are, the adoption is more and more. So when a book first comes out, it doesn't, of course, get adopted probably until like 9 or 12 months later, because it takes a while to change all of those syllabi. But yes, we are seeing increased adoption rates. And I know, Ines, you've been talking to your colleagues as well.
Yeah, I work a lot in the non-academic areas, and where I see the most traction with interest in the textbook are practical users, professionals who are working in the field, population health leaders, value-based care teams, analysts that are part of healthcare organizations reaching out to me and asking for the information for the book so that they can use it as part of their teams. And the beautiful part is that, Dr. Sylvia with Forest View offers like a way to handhold those organizations through the process in the book with her offering of Team View that she talked about earlier.
I think it would be cool if you had like a accessible one for healthcare professionals, like some sort of digital sort of eight whatever course, where everything's digitized. I guess you do have a learning management system that you were mentioning that you use as part of your onboarding. I could see that being really helpful to people across healthcare, and so anyway.
Yeah, there are organizations as well, like the Health Data Analytics Association has a population health interest group, and that group just keeps getting bigger and bigger. We have over 120 people that signed up for that, and that just keeps getting bigger. So in those forums, I've actually been on meetings with people where I see the book on their bookshelf in the background with some of the clients that I work with.
Or somebody will raise their hand and say, "Oh, I know you. I have your book."
And, it is a reference manual. There's a lot in there that when you're doing analytics or when you're doing this work, you need to look up as well. So I do see that when people get it, they don't let go of it. And so even through Forest View, at least 500 analysts have that access to that book now. So,
wow.
Yeah,
and I would say over 200 practicing healthcare professionals on my end have it in their hands as well.
Well, today's been a success to have you on. Is there anything we should, allow our audience to know about yourself before we're coming towards an end? Anything that we've missed? Anything you want to let our viewers, audience know?
I would say, please reach out to me. I love having conversations about this, and I love just speaking with people who are interested and want to, talk about where they are in their journey and improve that. So I'm at martha.sylvia@forestview.com, and you look at my website. It's great. You can find me there.
Yeah, and I would just leave with the message that this is really tough. It's really hard stuff, and it's really hard to be on the side of the changing the healthcare system and helping it to evolve in a way that benefits more and more people that it serves. And that we don't have to have all the answers or know exactly how to do it. And I agree with Dr. Sylvia, reach out to us. If you see us, hear us, or, have the book yourself and have a question about it, we welcome the dialogue, and just very thankful to have been a part of this podcast.
Cool. It's been great to have you.
Very much for having us.
Thank you. And the last thing is, whoops, sorry about that. I was just wanting to ask, before I put it out there, please think about anything that you think could complement our conversation today, any notes, whatnot. What we can do is just share that to our audience. When I send out the letter that kind of complements each post of the podcast, I would really encourage the two of you, if there's like an aha moment. Usually it's kind of like when you're at the doctor's office right when you leave, unfortunately, the one thing. But I think we did cover a ton of everything's perfect. But just if there is anything else, please feel free to email it to me, and I'll put it out there for our audience as well.
Yeah, I have what just comes to mind immediately is I have a one-pager that kind of describes our textbook and kind of a little bit of what we talked about today. And I know, Martha, you have the Forest View kind of information to share as well. I think they're complementary to one another.
Yeah, that would be great. Well, until next time, everyone have a wonderful 2024. It's coming up soon. It has been a great journey today on Planetary Health First, Mars Next. Follow us for more on Planetary Health First, Mars Next. Until next time, peace be with you.